Okay, welcome all to the second program of Indian Specialty Section, Psychopharmacology Section, and today we have eminent speaker among us, Dr. Raman Deep from AIIMS, and Dr. Nilesh Shah, Professor of Psychiatry, Professor and Head of Psychiatry for years at Sion Hospital. He has been my mentor, my examiner as PG, and I think all of us know him very well in the academic domain. So, sir, without taking much time, I will request you to introduce Dr. Raman Deep and then start the today's program.
Good evening, friends. And as usual, I'm very happy to be over here. And I'm grateful to the Psychopharmacology Specialty Section of Indian Psychiatric Society for organizing this wonderful webinar and giving me this opportunity to chair this session on treatment of bipolar disorder, synthesis of latest evidence and future direction. And to tell us a little more about it, we have Dr. Raman Deep, who has done her MD Psychiatry from AIIMS. She was senior resident at AIIMS and now she is a faculty member at AIIMS, which is one of the topmost institute of India, All India Institute of Medical Sciences. And she is the most appropriate person to tell us about it because bipolar disorder is one of her main areas of interest apart from suicide and psychiatric emergencies. And see her achievements, 120 published papers, 25 chapters in books, and probably many of them might be on bipolar mood disorder. She is also a recipient of very prestigious award of Indian Psychiatric Society, which is for young psychiatrists, Tilak Venkoba Rao Award in 2017. And that is for people having less than 40 years. So I assume in 2017, you had not crossed 40 years. She has served as a principal investigator and co-investigator on a number of projects. And she has been on editorial board of books. She has been a co-editor. She has been teaching and training MBBS, MD students, PhD students. And she has also been convener of IPS subcommittee on research and training. So no wonder she is going to tell us today about treatment of bipolar disorder and what is latest. And she is not going to read out the paper by paper, but she has synthesized the latest evidence and she is going to give us the ghee, not the milk, but the most important things out of the literature. So thank you, Dr. Raman Deep, for coming over here and giving us this lecture. Please take over and you may start your presentation.
Thank you, sir. And wherever I lack in this presentation, I'll seek your wisdom and a very vast experience. Greetings to the IPS office bearers. I can see Professor O.P. Singh and Dr. Brahma. Also greetings to all of you. Very thank you to the IPS Psychopharmacology Subcommittee, the chairperson, co-chairperson, convener, and all the members for giving me this opportunity to interact with all of you. And I hope I will be able to finish, that is in the next 45 minutes. I would also request Dr. Tyagi sir, if he can just remind me at 45 minutes, or rather at 40 minutes to wind up, and whatever is left, we can then take it up in discussion. I hope my slides are visible, sir.
Yes, they are.
Yes.
So bipolar disorder. Let us have a very quick recap on what kind of illness are we dealing with. If we focus only on Indian data, an estimated 76 lakh individuals are suffering from bipolar disorder in India. And this is as per estimation by the GBD Indian paper. We know the lifetime prevalence of bipolar disorder is close to 1% in the worldwide literature. And in the recent Indian studies conducted in the last 1 to 2 decades, notably the NMHS study across 12 states and the Indian data from the World Mental Health Survey, of which I was also part of that paper, the prevalence for bipolar disorders is close to 0.5%, which is what brings us to an estimated around 70 to 80 lakh of people suffering from bipolar disorder in India. Now, if we look at treatment gap, there is a vast amount of treatment gap, and it has ranged between 70 to 95% specific to mood disorders. Now, this disorder begins very early in life. Now, it has on paper a trimodal distribution, but if we club the first 2 peaks, that's the green and the orangish peak together, that amounts to close to 80% of individuals who have the onset between 15 to 30 years of age. So this disorder largely begins at a younger age, at a productive age, at an age where often the youth is moving out of the home and into academic institutes and so on. And only 20% of the individuals have a relatively late onset. The median age of onset is around 23 years. We know, I don't need to reiterate, we know that at 1 year, syndromal remission may happen, but symptomatic remission lags behind terribly. And at 5 years follow-up, a large majority of patients do relapse. And when we say large majority, it's between 70 to 80, 85%. I'll just summarize a few things from the long-term course, which is, if we see to 10 to 20 years course, we find only half of the time period is spent fully asymptomatic, while for nearly rest of the half of the time period, there is at least 1, often 2 or 3 symptoms which are ongoing. And those symptoms are not always syndromal. They can be subsyndromal depressions, minor depressions, major depressions, subsyndromal hypomanias, and only a small proportion of the time is spent in manic episodes. And of course, the mixed presentations. And overall, if we only focus on bipolar 2, it's phenomenologically speaking, essentially a chronic depressive illness, because 82.4% of the total ill time is spent depressed. So there is chronicity of the course. Subsyndromal symptoms are much more common. Affective symptoms are often in a dimensional continuum. There is a dominance of both depressive episodes as well as symptoms. There is a significant psychosocial impairment, not only in the syndromal states, but also in the subsyndromal states as well. And it was also seen that nearly 1/3 of the people with bipolar disorder have more than 5 shifts or changes in either severity or polarity per year of that 1 to 2 decades of follow-up. So affective symptoms often change in severity or polarity in a given year. And another learning from those very long-term prospective naturalistic studies is that incomplete remission is a harbinger of relapse or recurrence. Those who did not remit fully relapsed 5 times faster compared to those who had full interepisodic recovery. And why I am pointing it at the outset is I would want all of you to keep this long-term course, which is based on solid research in mind while we are dealing with the treatments of bipolar disorder. Now, coming to the IPS-funded multicentric study, which was led by Professor Grover, sir, and of which I was also a part as one of the sites. Now, of course, the limitation was that it was a retrospectively ascertained course and it was a hospital-based sample. Now, within that caveat, this is probably the only Indian data which is available for these many patients. And the course largely matched that of Western data, but with some differences. The differences notably were that probably there were more manic episodes and more patients who had predominant polarity as manic. But it could also be a factor of that retrospective bias could have come into play because people remember the manic disruptions more easily. And also more severely, manic patients often tend to visit hospitals. Lifetime rates of psychiatric, medical, and substance use related comorbidities remain very high. And also suicide attempts in close to 1/3 of the patients is a significant and preventable cause of both morbidity and mortality, because we know as many as 10% of the people will die by suicide over the course of their lifetime. There are also childhood antecedents in the form of ADHD, which was found in close to 9.5% of the STEP BD sample. All of it has relevance for treatment of bipolar disorder. There is also some Indian data to say that probably those with bipolar diagnosis, and especially if males, have more lethal attempts. Neurocognition is another issue. We know there are a lot of cognitive deficits. They appear very early in the course and they persist in euthymic periods and interfere with functionality. This is the 1-year follow-up study. This is the only longitudinal study from Indian subjects, and which showed that at each follow-up every 3 monthly, the cognitive deficits were there in bipolar sample compared to healthy controls. Now, of course, it's a multifactorial disorder, but it's one disorder in psychiatry which has a very heavy genetic loading, and there are gene-environment interactions, and of course, epigenetics come into play with downstream changes in neuronal excitability, possible mitochondrial malfunction, loss of dendrites, neuronal loss, neuroprogression, and also disturbances in the homeostatic regulatory mechanisms which control our mood. And that further leads to downstream changes in the form of behavioral manifestations or changes in the mood and functioning. Mood, energy, psychomotor activity, change in thoughts, and biorhythmic disturbances remain the hallmark of all the mood disorders, and especially bipolar disorder. There is also some debate to say that these are named as mood disorders, but last 10 to 15 years research is more geared towards energy. And it's possible that bipolar disorder could be occurring because of phasic dysregulation in the mitochondrial bioenergetics. It's essentially an energy disorder arising from mitochondrial dysfunction. So coming to the treatment of bipolar disorder, we know there is an acute phase, and our goals of treatment vary according to the phase which we are dealing with. In the acute phase, the focus is managing the psychiatric emergencies, managing the immediate symptoms of the mood states. Continuation is something where we don't withdraw the doses on which the patient has stabilized. We allow the patient to sustain on the same dose on which he or she is stabilized in the acute phase. Typically, continuation phase continues for several weeks to few months. Most of the guidelines say that continuation phase is around 8 weeks. But conceptually speaking, we know that episodes take much longer for biological remission, and continuation phase could last for several months as well. And that then merges into the maintenance or apparently well phase. But recurrences are part and parcel of the course. And so the goal of the clinician varies according to the phase, and one should retain a dual focus. both keeping an eye on the short term, but also keeping a long-term focus. So the Indian Psychiatric Society clinical practice guidelines are available on bipolar disorder. They are from the year 2017. And it has summarized some of the foundations or the general principles which we must take into account while dealing with the subject of bipolar disorder. So well, I'll not go into too many details, but I'll give an overview, which is the guidelines talk about the need to establish the diagnosis, to rule out the relevant comorbidity, to rule out the relevant differentials, especially whether it's a substance-induced disorder, whether there is any organicity at play, or whether it could be schizoaffective or other kind of psychotic disorder, whether there are atypical presentations. The guidelines also emphasize the need for a very detailed clinical assessment covering the various domains before we venture into treatment. Also, a clinician has to decide about whether it's inpatient setting or it's going to be an OPD setting, and various available modalities such as pharmacotherapy, ECT, now these days neuromodulation, or other non-pharmacological therapies has to be chosen. The guidelines then give details about all of the various drugs which are available, and also emphasizing that the choice of medication should be dictated by many factors such as cost, affordability, the past history of response, the presence of comorbidities, and other factors such as safety and tolerability. The measures to improve medication adherence, while they are listed, and interestingly, there is also a point that always ask the patient what kind of formulation, like tablets, and we know certain tablets, certain capsules are not acceptable by patients so easily. Divalproate, for example, a tablet is quite big in some of the companies, so it asks to focus on the small nuances which may go a long way to improve the medication compliance. It also gives a bit of grading of evidence based on the evidence which was available till 2017. Some of the other general rule of thumbs, like while managing a manic episode, one must first stop antidepressant, one must first optimize the dose of whatever the mood stabilizer is a patient on before venturing into the further addition, etc. The guidelines seem to prefer bupropion, especially over some of the SSRIs like paroxetine, and advocates it for the management of bipolar disorder, of course, in a stepwise approach. And then it talks about the various special situations which may arise, such as suicidality or comorbidities, etc. There were also parallel guidelines for children and adolescents in the same time frame. So beginning with the prophylactic treatment of bipolar disorder, because when we discussed about a very long-term course, it might be worth the while to first begin from the maintenance treatment of bipolar disorder. So what should be an ideal mood stabilizer? There are a lot of definitions and there is no single solid definition, but what is generally agreed upon is that an ideal mood stabilizer should work on both acute as well as prevention for manic as well as depressive polarity for at least about a period of 12 months or more, and along with the demonstration of safety and the demonstration of efficacy for acute and long-term management of manic and depressive, it should also not worsen or destabilize the course of the illness. And so ideally all 4 squares should be full, and lithium probably is the closest one which comes, but it also falls short in certain regards. The CANMET guidelines talks about the general principles, the need to optimize the existing therapy before going into first line, second line, and third line agents in a hierarchical fashion. Now, these guidelines are from the year 2018, and the first line management for long-term treatment of bipolar disorder, what is recommended is lithium. Lithium has level 1 evidence for prevention of any mood episode, prevention of depression, as well as prevention of mania. The only medication in the first line therapies which come close is quetiapine, and lower down we can see a combination of quetiapine with lithium or divalproate is another medication combination which fills all the circles green, that is level 1 evidence, either in the form of meta-analysis, a good quality meta-analysis, or a replicated double-blind RCT. Now, divalproex prevents any mood episode, but falls a little short while preventing the manic episode especially. And similarly, lamotrigine, while it has good efficacy for prevention of any mood episode, but we know it is not as efficacious as far as the manic polarity is concerned. Acinapine, we know it's a sublingual formulation. It is a newer addition in this guideline, and it's a change from the previous CanMed guidelines, and it has level 2 evidence in all the phases. While aripiprazole there is a questionable or no efficacy with the available evidence for prevention of depression. Coming to the second line treatments, risperidone long-acting injection, the risperidone depot, either as monotherapy or as adjunct, has demonstrated efficacy at least in the prevention of any mood episode and to a certain extent in prevention of manic episodes. Now, if we see at the topmost row, olanzapine is one other medication which has a level 1 evidence for all 3 phases, but it is, as we know, pulled down into the second line treatments because of the weight gain and metabolic and various other concerns about metabolic syndrome and related comorbidities. So because of the safety concerns, it was pulled down. And one of the recent developments have been olanzapine samidorphan combination, which could change the next edition of these guidelines. Now, this particular combination was recently approved as an acute treatment for manic or mixed episodes, as well as an adjunct to valproate or lithium for manic or mixed episodes. Now, samidorphan is a opioid receptor antagonist, which is very similar to naltrexone in terms of its chemical structure, but it has a very long elimination half-life, and also it has several times higher binding affinity to the opioid receptors. And when SAM was combined with olanzapine, it was shown to mitigate at least some of the olanzapine-induced weight gain without losing the efficacy of olanzapine. But when we see in terms of published literature specific to bipolar 1 disorder, not related to psychosis or other disorders, specific to bipolar disorder, there is only one randomized controlled trial, very, very recent from this year only. And it was a short duration RCT, as RCTs are usually, that's 12 weeks duration. And samidorphan was 10 milligram in combination with varying doses of olanzapine. And it was seen over this 3-month period, the percentage weight gain was lower in olanzapine samidorphan subgroup, but it was a small marginal, but a significant difference. As we can see, in 3-month period, it's 4.91 versus 6.77 in the other group. So the long-term efficacy in terms of the advantage in reducing the metabolic or the obesity or the other parameters associated with olanzapine remains to be seen. And we really have to see it in 6 to 12 month kind of studies. Now, for patients who fail to respond to the first line agents, and all of them have to be tried ideally in the given order, but we know that's not how real life works and various other factors come into play. But the CANMET guidelines generally advise to exhaust the first line and then the second line agents before moving on to the third line agents. The CANMET guidelines also allow certain flexibility that while going further down in the hierarchy, there is an option to either add on or to completely switch. So for example, if one begins with lithium and if lithium does not seem to work fully well, one can choose to shift to quetiapine, but more often what is tried is addition of quetiapine. So it's either an add-on or a switch to the next agent. However, for the treatment-resistant patients who fail multiple trials, the third-line therapy include clozapine specifically. We know it works wonderfully well, not only in schizophrenia, but also in treatment-resistant bipolar disorders, provided the patient has the means and resources and can monitor closely or can be hospitalized for a certain duration. So wherever the safety, tolerability, and other practical considerations allow, clozapine, often in lower doses, as little as sometimes 100 to 150 milligram, tend to stabilize the long-term course of bipolar disorder in treatment-resistant patients. However, as we can see from the circle, there is only a level 4 kind of evidence which is available with clozapine, and it's likely because many of us use it more, but the publication part of it is relatively less. Also, we have some evidence that probably Indian populations, Asian populations need lower doses of clozapine, as is also seen in other agents such as buprenorphine or even the lower levels of lithium, etc. But those kind of published guidance is not available. But it's a good agent out of these few agents which are listed as third line agents. Finally, certain agents do not carry any recommendation. They have no specific recommendations, or rather they are not outrightly recommended. Cariprazine is one of them. We know it has more efficacy in the acute phases, but as far as the prophylactic efficacy goes, cariprazine falls short. So further, if we follow up the patients for a very long term, as many as 2/3 of them might require a combination therapy. And this is not something which is unique to bipolar disorder or psychiatric disorders. We know a lot of other disorders outside of psychiatry also tend to require combination therapy, such as hypertension is often quoted, etc. But in the first few years, patients may stabilize on monotherapy, but as the course progresses, some of them might require the addition of at least one more medication to control the breakthrough episodes or for a better and fuller remission. Because as we already saw in the long-term course, that incomplete remission is associated with more likelihood and an early relapse. But there could be other factors. For example, an illness which is naturally, which has naturally more illness activity or more illness pressure will also tend to remit less and will relapse early. However, as clinician, wherever possible, one must make an effort to have fuller and complete and sustained remissions. A general rule of the thumb is, if the patient has responded to therapy, be very, very conservative in making changes. Let the patient be on the same combination or the same agent for the coming months before making a change. But if the patient is not responding well, then instead of being conservative, be a little more aggressive and try out the other treatments, either by add-on or by switch strategy. So then the next question comes, whether the patient for prophylaxis should be given a mood stabilizer alone, or a combination has a superior evidence base. So mood stabilizer alone or a mood stabilizer plus the second generation antipsychotics. And this question was addressed by a meta-analysis of only the double-blind RCTs with close to 3,000 patients. However, at the intake, these RCTs took the patients who were already clinically stable on the combination. And thereafter, in the intervention arm, both of the agents were continued, but in the control arm, the second generation antipsychotics were replaced by placebo. So it was a discontinuation design. Now here, the DIS stands for the discontinuation subgroup, and the other one is maintained the same as before. And we can see that at 1 year follow-up, those who had discontinuation of the atypical antipsychotic had a much higher propensity for recurrence of any mood episode. But I would like to emphasize that while that may be true for a subset of patients, but an important caveat in all this meta-analysis was that since it recruited already enriched samples, these were the patients who already responded to the combination, who already were stable on combination. So these findings can't be generalized to those who respond well to monotherapy of mood stabilizer. But at least of those patients who require a combination, probably continuing the combination for the first few months or a year might be useful in reducing the recurrence rates. Now, this is bipolar 2 disorder prophylaxis, and we know very less evidence is there when compared to bipolar 1. Quetiapine is one agent which has level 1 evidence for maintenance of bipolar 2 disorder, followed by lithium and lamotrigine. Now, in the second line therapies, unlike bipolar 1, where the use of antidepressants is very, very conservative and often for short duration and after exhausting other options, and even then in combination, not as monotherapy. So in bipolar disorder, venlafaxine, which is an SNRI, as well as fluoxetine are given as second line therapies. And the reason is that all the available research largely points to very, very low switch rates in bipolar 2 disorder. And many studies suggest that the treatment emergent effective switch is probably somewhere close to general population or the other disorders rate. So unlike bipolar 1, the switch rates are much lower, and therefore the use of antidepressants is a little more liberal over here. But olanzapine had insufficient data. So once stabilized, especially in the first episode mania, there is no clear guidance on how long to continue. But unlike a depressive episode in which the general recommendation is 6 to 9 months, maybe a year, the recommendations generally are much longer for first episode mania, perhaps up to 3 years. However, when the illness becomes recurrent, severe, or suicidal, then the maintenance has to continue for long term. And long term often means several years, and in some patients, lifelong. Of course, there are some exceptions, and we once in a while, of course, come across patients who have very low illness pressure, who have only one episode every 10 years or so, and they come to our OPD in 2006. Maybe they might have met me once, and then they come in 2016, and then now. But such patients are far few and in between. For a large majority, they'll require a long-term maintenance if they have multiple episodes. Of course, pharmacotherapy has to be combined with non-pharmacological measures, and especially psychoeducation, even if the more detailed therapies are not feasible or the resources are not available. The social rhythm therapy is a very biologically based non-pharmacological management, though the published evidence is not as high. There are 4 to 5 controlled trials which are available, but theoretically the concepts fit very well with what we know about bipolar disorder. So another major question as far as the long-term treatment concerns is lithium still a gold standard for prophylaxis? Especially, we know it was one of the first agents in psychiatry, one among the first few, and a lot of new agents have come, and there is a trend in the recent decade towards replacing it with the second generation antipsychotics, which some consider are probably better, and it's at times better to convince the patients or parents or caregivers, and probably it's a bit easier for the clinicians. So many times the question arises, is it a gold standard still? So we know at least a subset responds wonderfully well. They are excellent lithium responders. They stabilize soon and don't, and their relapse rates are much lower. So this subset, about 1/3, probably also holds the key to pathophysiology or the etiopathogenesis of bipolar disorder, because unlike other drugs, lithium is a class of its own. There is no such drug which is available in the same category. We know there was one medication which was lithium mimetic, and it was in the production, but it never came out. As the prescriptions showed declining, the BALANCE study reaffirmed the case for lithium. The BALANCE study was a landmark study because when compared against valproate monotherapy, there was a definite prophylactic superiority of lithium established. And though, of course, a combination of lithium and valproate also worked well, but used as monotherapy, it was found to be superior in this 2-year follow-up period. Now, besides that, there is also large evidence from naturalistic cohort studies which affirm the superiority of real-life lithium monotherapy. And maintenance had better outcomes than any of the other mood stabilizer monotherapies, be it valproate, lamotrigine, or the atypical antipsychotics such as olanzapine, quetiapine, etc. And this data in the form of systematic review comes from close to 14,000 patients' data. And all of these were naturalistic cohorts. Also, if we see that how long the monotherapy survived without any relapse or recurrence, lithium survived the longest compared to the other agents. Lithium also has the largest database available till date for the placebo-controlled trials. And it will be very good to look at it visually in this network meta-analysis. The thickest line which connects lithium and placebo shows the comparison against all the other lines which are available with all the permutation combination of other RCTs. So placebo-controlled trials are they are the largest in lithium database. And so therefore we can be more confident. It has been tested over many decades and it has a more solid evidence. Now there is one more difference when we talk about lithium compared to other agents. 17 out of the 19 of those lithium studies were prior to the era when enrichment designs became more common. So the non-enriched designs are more robust. And lithium, when it was tested, it was largely tested in the non-enriched designs. Enriched designs are basically that at the intake, one takes only those patients who have already responded well to that particular agent. Now coming to the real world hospitalization rates, all-cause hospitalization was lowest in the lithium subgroup. And when we compare that with quetiapine, it showed only modest effectiveness. And again, it was a very large Finland cohort with a follow-up of 7 years. Anti-suicidal effects are well known. Lithium also is supported by almost all of the practice guidelines. There are at least 5 practice guidelines which we know of, which are there in the last 3 to 5 years. And lithium, including in CanMet, has been shown to be effective at all phases of bipolar disorder. Now, there are benefits beyond mood stabilization, and that include neuroprotective effects, peculiarly a shift from eveningness to morningness, that is a change in circadian rhythms. We know there is a preponderance of evening chronotype among bipolar patients, and those with evening chronotype are also having a worse course. They also tend to gain more weight, tend to overeat at night, tend to have more behavioral addictions, and tend to have more episodes. So lithium, with some support, has been seen to shift the rhythm towards morningness. In addition, in the preclinical studies, it has also been shown to have antiviral, anti-tumor, and immunomodulatory, and probably anti-aging effects. So it might be a disease-modifying drug. It might make sense that if one has to choose lithium and if patient doesn't have any contraindications, it might be started early in the course because of the neuroprotective effects. It might slow the illness progression. The evidence for lithium neuroprotection, I'll not go into detail, but it's robust. And it has emerged largely in the last decade or a little over that. And by now, it has accumulated in the form of meta-analysis as well. It also is associated with a lower risk of dementia and a better recovery in stroke. This we have already discussed. The main concern with lithium is some apprehensions about its safety and the need for a very close monitoring. However, all that can be mitigated with preventive strategies, large amount of course, psychoeducation, periodic monitoring, and the educating the patient and calling every 3 months or so. Or if the person is elderly, then of course one has to be a little bit more careful and educate. So a lithium counseling session at the intake is something, and along with the other educational material, it can circumvent some of those concerns. Also, when we talk about safety of lithium, what about the tardive syndromes, the metabolic burden, and the exacerbation of OCD symptoms which happen with antipsychotic agents? The so-called antipsychotic agents, of course, the name is misnomer, but the dopamine blocking agents are also associated with their own set of side effects. And when we talk about other mood stabilizers, they can also have very severe dermatological, life-threatening emergencies, along with hematological and other liver derangements. In fact, that is one of the reasons why carbamazepine is lower down in many of the phases of bipolar treatment. And again, the concentrations which are required in Indian population might not be too high, though that evidence is not fully available. But there is some data to say that people might do well somewhere around 0.6 or around that. And it is only in the acute phases that one may require to reach higher level. But of course, while preferring an agent, many other things in the clinical course also have to be considered, such as whether there is rapid cycling, whether there are comorbidities, whether there were 10 episodes in the past or only 2, and so on. And we are all familiar with the factors which make one choose lithium versus valproate. However, these are not laid out in stone. To give an example, in rapid cycling, usually it is said that valproate is preferable. But when we look into the data, it is not that lithium does not work in rapid cycling. It is only that the response rates in rapid cyclers are relatively less compared to the non-rapid cyclers, but they are not zero. So the difference might be something like 50 to 60% versus 25 to 35% also. And of course, there are situations in which, for example, if person has comorbid migraine or comorbid epilepsy, or more atypical presentations, we tend to avoid lithium and choose the other mood stabilizer so that the patient is not exposed to too many agents. Now, coming to the acute treatment of mania, I'll go through it relatively quickly because the maintenance is something which one must keep a focus on. In the acute agitation, loxapine inhaled version has the level 1 evidence and FDA approval. Of course, it's not available in India, and it's also associated with the bronchospasm. So it has to be given in medically certified licensed kind of settings. The most common agent which we all use in our setting, haloperidol promethazine, that is a second line agent, mostly because of lack of published data. But in the first line therapies, the intramuscular olanzapine or lorazepam or some of these agents can be preferred. Now, in the first line monotherapy for acute mania, again, lithium is given in the CANMET guidelines as the first choice, followed by quetiapine, divalproex, acinapine, aripiprazole, paliperidone only at higher doses, and followed by risperidone and cariprazine. So almost all first-line agents show comparable efficacy, and the hierarchy is based on a lot of other considerations. But while choosing a medication, we should also look into which medication can benefit some of the symptoms which the patient is experiencing. For example, quetiapine at lower dose, 50, 75, works very well for anxiety, which is often, or the symptoms which DSM-5 now specifies as anxious distress, and the more sedative, more hypnotic kind of properties help to calm some of those patients down. And so the medication choice can also be customized based upon the clinical needs. Apart from lithium, though not as robust, valproate and quetiapine has very low quality evidence that most probably it might have some protective effect on suicide, but apart from lithium and clozapine, no other drug has very robust evidence for being anti-suicidal. Now, whether to go for monotherapy or combination, because if we see this table, both are given as a first-line treatment. So we can pick and choose, and whether to prefer the first one or the second one will be determined by how severely ill the patient is and how rapidly we want the response. So if it's a severe or psychotic mania, go for a combination. If we need for a rapid response in a highly aggressive, at-risk patient, we can go for a combination. And typically here at our setting, the inpatients, those who are admitted, typically are put on a combination because they are more severely ill patients. But in OPD, milder presentations, one can go for monotherapy. The second line agents include olanzapine, not because of lack of efficacy, but because of safety considerations. But as we already discussed, that in combination with samidorphan, it's possible that might change if more long-term studies are published by then. Now, the patients who fail to respond to the first, both the lines of therapies for acute treatment of mania might respond to chlorpromazine. There was a time chlorpromazine was used much more often. I had a few patients who actually stabilized on chlorpromazine, and they were ECT resistant patients also. And they stabilized on chlorpromazine, but then it, of course, few months passed, and they thereafter for the coming time could not be stabilized on anything else. So while it's not an approved long-term treatment because of various complications, but once in a while where nothing else is working, one can go for that, especially in long-term hospitalized patients whose symptoms are not remitting even with multiple other treatments. Clozapine, of course, if there are no contraindications, can be again considered for resistant manias. Tamoxifen is given here, but it has some safety concerns as in risk of uterine cancer, etc. Endoxifen is one of the newer agents. It's a protein kinase C inhibitor, but it also has a single RCT available till date, though from what we know, a lot of people are using it across India. And so it's possible that the practical knowledge gathered from all those prescriptions might be much more than published data. But this was a single phase 3 trial at multiple sites. So this commentary was published just today itself. Today morning I got it. And of course, there are some valid questions like the process of approval of endoxifen based on one trial, and that too had some methodological issues. And also one other concern comes is the cost effectiveness. So this is one which, and also because it's related to tamoxifen, we as of now are not sure about the very long-term safety, though mostly it is used in mania for short-term. So this is one molecule we may have to see over the coming times. Some of the agents like lamotrigine are clearly not recommended. And the other guidelines, Australian guidelines, are largely very same in the respect of a manic episode. When we talk about the pharmacological treatment for bipolar mania, this is a systematic review and network meta-analysis only of RCTs. And there are two salient observations from this particular meta-analysis, which is that lithium and valproate were effective for acute mania, but somehow they ranked lower in the efficacy outcomes. They were lower down compared to most of the other antipsychotic agents. The other clinical variable in which antipsychotics were found to be useful was in the presence of psychotic symptoms, when the mood episodes were psychotic. Those cases, antipsychotics probably do better, whereas the traditional mood stabilizers did not. So these were the two observations from this large-scale clinical trial data. So in a nutshell, lithium, of course, remains the first-line recommendation, and several other atypical antipsychotics, they also have good base, both in monotherapy and in combination for acute treatment of mania. But one generally would not make a choice which one won't want to stick in the future with. So again, to retain a dual focus. And it's possible these days, first episode patients may prefer atypical antipsychotics, and till the time the second episode come, they often in the first 2 year, 3 year, 1 year, they may be continued only on atypical antipsychotics, provided they don't have any other red flags such as a family history of suicide, etc. So what about hypomania? Not many medications are studied for hypomania for obvious reasons. They don't come to hospitals during the hypomanic phase, which is typically missed. Only 4 agents have been studied. These are listed here. Again, the evidence is not too high. So in absence of reliable data, it might be useful to treat hypomania similar to the clinical experience which is gathered from antimanic medications. Some of the other guidelines other than CanMet recommend quetiapine and risperidone for hypomania. And it's possible hypomania would require lower doses. Coming to bipolar depression. Now for bipolar depression, which we know is the most difficult out of all of these phases to treat sometimes. And we have also seen in the course that the depressive phases, either symptomatic or syndromal, are 3:1 in bipolar 1, but 37:1 in bipolar 2. So there is a depressive preponderance over the long-term course. The first-line monotherapies which are recommended are quetiapine, which has level 1 evidence, followed by lurasidone in combination with either lithium or divalproate. And thereafter comes lithium, lamotrigine, lurasidone, and then adjunctive lamotrigine. So in this particular phase, unlike the mania or prophylaxis, lithium ranks lower down compared to quetiapine. Now, both quetiapine and lurasidone separated from placebo as early as week 1. And of course, in bipolar depression, while we have some of the faster acting agents, such as ketamine, but typically, as we have already talked about suicidality, ECT may be more useful, especially in achieving the remission. And again, while using ECT, one might prefer ketamine as an anesthetic, though I would want to say there is no published evidence as such. All of what we are talking about here is anecdotal. And ketamine otherwise has shown good responses in short-term control of suicidality, and though the effect doesn't stay for very long. Recommendations for bipolar 1 depression as second-line therapies include divalproex, but it is then followed by SSRIs or bupropion. And bupropion has lower switch rates in bipolar 1 disorder, and sometimes it's a good addition, provided the patient is adequately covered with first-line mood stabilizers. Cariprazine also till then, till the time the guidelines were published, had level 1 evidence. More recently, there is more data available on cariprazine in the form of meta-analysis of 7 RCTs, and it is shown to be efficacious at the doses between 1.5 to 3 milligram per day in acute bipolar depression, though the effect sizes were rather small. Also, this is another recent paper, which is more of a post hoc analysis. Again, it talks about the efficacy of cariprazine as monotherapy in bipolar depression, but it also talks about a good efficacy of cariprazine in 3 to 12 milligram dose for acute manic and mixed episodes. And of course, EPS remains a concern even with cariprazine, but there are not significant metabolic concerns. Another agent which was recently approved for bipolar depression was lumateperone. Now, it is a bit novel mechanistically speaking. It is an antagonist at 5-HT2A receptors. On these receptors, pimavanserin is the inverse agonist, but it also has many other actions other than this receptor. It also binds, though with lower affinity, to dopaminergic receptors and affects AMPA and many other pathways. It has both antipsychotic as well as antidepressant properties. And as far as its use in bipolar is concerned, it's more recent development. Again, when we talk about the published data, this is the phase 3 placebo-controlled RCT of lumateperone in bipolar depression. And the conclusions of this RCT was that lumateperone at the doses of 42 milligram, because in this RCT, 28 milligram dose was also taken. So lumateperone at 42 milligram dose significantly improved depressive symptoms as an adjunctive treatment to lithium or valproate. And it appears to be well tolerated from the initial data, but it remains to be seen. Lumateperone also has some post hoc analysis where it was found to be effective in bipolar depression with mixed features as well, in addition to those without mixed features. So once it comes, it might be a newer agent to try out for mixed presentations. And we know for mixed presentation, the treatment options are, the evidence-based treatment options are relatively less. Now, very quickly, this is an Indian paper. It is from NIMHANS. It was a multi-site paper from 3 countries. And the study proceeded over many years. The essential question which was answered by this study was that is there a need for adjunct antidepressant maintenance for long term in bipolar 1 depression? Now we know, traditionally speaking, one is asked to taper off antidepressants as soon as possible. So antidepressant maintenance seems a little counterintuitive, but the research question which was addressed was that if patients who were stabilized on either escitalopram 10 to 30 milligram or on bupropion 150 to 450 milligram for the preceding 16 weeks, once they were followed up very frequently for the next 52 weeks, that's 1 year, and divided into 2 groups. In first group, the antidepressants were tapered at 8 weeks, that's 2 months after stabilization. In the other group, the antidepressants were continued for the first year or so. And during this time, patients were assessed every 2 weeks. Though because of some logistic and funding concerns, the assigned the study had to be curtailed a little bit, but the data which is available with us from this recently published paper in NEJM, the main finding was that continuing adjunct antidepressant therapy for 52 weeks was not more beneficial as compared to discontinuing it earlier. So it kind of affirms what we already knew, but it gives it in the form of a very robust, closely followed patient data. Now, however, it was also seen that there was no significant harm or adverse effects reported in those who continued for longer term. Now, some agents are not recommended in acute bipolar depression, and antidepressant monotherapy as a monotherapy is one of them. And even in the previous study, it was given in combination as an adjunct. In bipolar depression, again, the treatment options are limited, but quetiapine works, has a good evidence base for bipolar 2 depression. So this is summary. Lithium works in all phases. I think we have already gone through that. I'll not repeat. Mixed features, very, very limited evidence. So I'm going to skip it. There are guidelines on both extremes of age. Now, what about cognitive symptoms? We talked about cognitive deficits. Are there some agents with pro-cognitive properties? Again, no good data, very resistant to treat, but whatever RCTs are available support modafinil or lurasidone as having some effect in improving cognition, but very, very sketchy, very, very limited evidence. To give an example, modafinil was tested only as a single dose of 200 milligram, and which was found to improve cognition. So we can't really draw much from this. But some of the atypical agents such as lurasidone, cariprazine, lurasidone, and vortioxetine, from their use in other disorders such as schizophrenia, we know that they might carry some pro-cognitive properties, possibly by virtue of their effect on 5-HT7 or D3 receptors, but who knows at the end of the day. So some agents have some recommendations, but the quality of evidence is very low. Again, I'm sharing this slide only because CanMet task force had a paper on it. None of these agents were recommended except for perhaps omega-3 fatty acids, especially EPS, but it was a very weak recommendation. And finally, I'm coming to the last 5 or 6 slides. In terms of future directions, when we struggle with the treatments, we know one size won't fit all. We know bipolar disorder is probably a heterogeneous illness with various etiopathogenetic mechanisms. And what we are seeing is phenomenology, and we don't have the sufficient tools at our disposal right now, though there is increasing research in biomarkers, but none of them has translated wonderfully well to the bedside of the patient. So there is always a search for that, are there certain etiologically distinct subtypes? And one of my favorites, of course, is the lithium responsive bipolar disorder. Perhaps that's something different from the other types. So there might be a case to study those 20-30% people who are excellent responders, but also CACNA1C mutation. We know this gene encodes for L-type voltage gated calcium channel. So I could find this. This is one textbook by Dr. Nasir Ghaimi. And it's a little different textbook. It doesn't talk about evidence base, more about expert consensus. And some of the offbeat treatments which they have recommended, and we know there is some evidence for that, is the use of calcium channel blockers such as nimodipine for those who have ultradian cycling or those who were tested and found to be positive for this CACNA1C gene. I have sometimes considered using it, and sometimes I have in very, very resistant patients, these ultradian cycling, especially finding if they have comorbid hypertension or such. So far, I have not used it, but I'm showing it not as an evidence-based treatment, but as some of the other kind of reviews and papers which researchers in bipolar have talked about. Now, the same researchers also talk about testing for inflammatory markers such as CRP, etc. And if they are elevated, then to consider for certain, only in that subset to consider for agents such as celecoxib, COX-2 inhibitor, etc. as opposed to using it for the entire sample. So, of course, no studies have been conducted in this subset. This is a recent paper on calcium channel antagonists, mostly as drug repurposing. So rather than discovery of new molecules, which is a $1 billion kind of project, so whether to repurpose some of the drugs which are already available for other disorders. Speaking of etiologically distinct subtypes, the continuous circular course in bipolar disorder could be one of them. So this is the life course of one of the follow patients, and we have a few, and I'm sure all of you would also have seen. So this is a continuous cycling course for the last 20 years, the patient has not been asymptomatic. Every 2 weeks, there is a change of polarity, and it's very predictable. It's rhythmic, it's circular, as in both upper and lower poles meet together to form a perfect circle. It's 2 weeks, 2 weeks, and it happens with a clock-like precision. In the traditional classificatory system, such patients are clubbed as rapid cyclers. Of course, they are not. Conceptually speaking, rapid cyclers, the emphasis is on the number of episodes per year. It doesn't matter in what order, what polarity. As long as it's 4 or more episodes, it's a rapid cycler. But as opposed to the number of episodes, it's the rhythmicity, the precision, the circularity, which is more important, and also the asymptomatic period. Peculiarly, this patient so far has not responded too well with almost all the first and second line options. So such patients are candidates for probably NGS or exome sequencing, and then finding further, digging further, which is also in the pipeline probably for this patient. So to conclude, a similar set of patients, this paper I'm showing only because it's published in Molecular Psychiatry, not a very easy journal to publish in, and that too with only 17 patients. So you can see the quality of the paper. This was a time series analysis of very small sample of rapid cyclers, and many of them had a cyclic course with a periodicity of 35.5 days. That's about a month. The authors did a longitudinal time series analysis, seeing the relationship between mood shifts and three kind of lunar tidal cycles: the gravimetric, the spring neap, and the declination cycle. And they could find that at least in some there was a mapping. And so they have proposed is that there could be a switch process which transitions based on the lunar tides. And they have hypothesized that similar to circadian system, the clock gene, the timeless gene, humans might also have a biological system that responds to the lunar gravimetric cycles, either directly or indirectly via intermediate variables. And out of these 17 patients, at least a few responded well to circadian-based treatments. Other novel therapies which are under study include dextromorphin, especially when combined with an enzyme inhibitor such as bupropion or quinidine. So dextromorphin is also an NMDA receptor antagonist. We know ketamine works in acutely suicidal patient in the short term, but it has the oral use is being done, but it might have the effects might be longer with dextromorphin as and when it comes, if combined with bupropion or other enzyme inhibitors. Deuterization of dextromorphin also extends its life. So that is another mechanism for extending the life, and we have to see. Now, methadone, we all know, is used for as an opioid agonist, opioid substitution therapy, OST, but the dextro enantiomer has more potent NMDA antagonist activity, similar to dextromorphin, but without the abuse potential and without a potent opioid agonist activity. And it might have a more rapid onset of action with some promising early results. And many other targets, of course, come across. We know glutamate system, opioid system, cholinergic system, then melatonin, agomelatine, melatonin receptor agonists, then anti-inflammatory agents, immune modulators, then mitochondrial modulators, then metformin, pioglitazone, and a lot of other agents. Also neurosteroid modulators. We did not talk about the derivative of allopregnanolone, the Brexo, which is now used for postpartum depression. But again, it has to be given intravenously over 60 hours duration and not a very feasible treatment, but it has been an approved treatment for postpartum depression. So some other neuroactive steroids, etc., are also in investigation. But as of now, for all these offbeat agents, guidelines do not have any recommendation and show a lack of evidence. Thank you.
Thanks, Dr. Raman. Very comprehensive presentation. And in the comment section, already Dr. Iman Das, Dr. O.P. Singh, Dr. Anukriti, Dr. Meenakshi, all have appreciated your presentation. Before we take up the questions, I would like to request our chairperson, Dr. Nilesh Shah, who was also the first author of the IPS CPG on bipolar disorders, to give his comments. Please, sir.
I fully acknowledge that it was a wonderful lecture, and she has very well described all the guidelines, and very important messages were given that which molecules are useful, what evidence do we have about the various molecules, and what all things we can use for the treatment of bipolar mood disorder. One thing which she emphasized was what many of us believe is that east or west, lithium is the best. So many of us continue giving lithium, and for younger population who are a little scared of using lithium, I think this will be a good message that lithium has been a good molecule, and with few precautions, you can use it in many patients. There are new molecules like endoxifen, and some people had a question on endoxifen, and many similar molecules will come. Many molecules are in pipeline, and many molecules you wanted to use. A very simple rule of thumb, which I usually share with everyone, is that घड़ी detergent टिकिया पहले इस्तेमाल करे फिर विश्वास करे. So whatever molecule, endoxifen or any other molecule, you want to try it out, many molecules will come. You yourself try it in your patients. If you find it useful, continue using it. If you feel it's not very useful, stop using it in that patient. Once again, congratulations to Dr. Aman for a wonderful presentation.
Thank you, sir. We will start with the questions. Before that, I request everyone to subscribe to our YouTube channel. I am pasting the link in the comment box. And also, like Dr. Ashish will be discussing about our upcoming offline program going to happen in Goa after we take up the questions. I would like to start with a question on endoxifen from Dr. Heyman Balsare. He wants to know, in a patient of bipolar depression who is actively suicidal, is there any role for endoxifen?
No.
Thank you. Dr. Vipul, you are there?
Yeah, I am there.
Yeah, please.
Yeah,
Yeah, please.
And my video is not working. Dr. Raman Deep, sorry, I could start late. Very well organized, very comprehensive. Thanks for accepting our invite. Dr. Shahul, you continue with the questions. I'm there.
OP Singh sir has raised his hand. Sir, please unmute and ask, sir.
Thank you, Saul. First of all, it is really one of the best presentation on bipolar disorder I've ever heard. So kudos to your team and Dr. Raman Deep. My problem is that lithium is of course the best, but in our kind of persons, they sometimes drop for 7 days, 10 days. Again, we ask them to take. So what happens then? Whether we should use lithium with those population or we should not? Because stopping them, lithium is worsens the course that I have learned. So that is I want an idea that whether they stop for some time and then again restart. So whether that is, what should we do?
Yes, sir. That's a very, that is often seen as a red flag. Now, there are two issues in that. One is patients or individuals who keep on stopping, restarting, stopping, are probably also likely to be careless in general in their outlook. And this can be seen as a red flag because if they are not too sincere about their treatment, they are also probably not likely to monitor or miss the early symptoms or likely to overdose it, as sometimes they do. Before coming for the testing, they may take it only 2 or 3 days in more doses. So I see it as a red flag, mostly because such individuals are not likely to be too adherent or compliant to treatment. Now about the second related part, which is whether such frequent stops and switches lead to a worsening of the course and a destabilization of the illness. Some time back, I looked into it because, of course, all of us talk about it at various academic forums, including in our in-house presentations or teachings. But when we look at evidence, that kind of evidence that where patients stopped lithium abruptly without gradual tapering and went into years-long rapid cycling, non-responsive, that kind of evidence was available only in very small reports about around 2001-2. There is no good quality data to say. But having said that, as a precaution, as is done in all the psychotropic, whenever we have to stop for any reason, it's always advisable to taper it over a course of 2 to 3 months or even longer. So yes, those patients are probably not suited patients for various reasons. Yes.
Thank you.
Thank you.
Dr. Meenakshi wants to know, in a patient of hypothyroidism, can we continue lithium along with the concomitant thyroxine?
That's a very good question. Recently, in one of my thesis, Dr. Anjali, we looked at the ultrasonic enlargement of size of thyroid. So it was a small sample, but we know from the literature as well as from our own clinical experience that hypothyroidism happens in a large proportion, especially among women. The rates can be, as high as 1 in 5. Hypothyroidism is a lithium-induced hypothyroidism, especially for females, is a common comorbidity, but it is not an absolute contraindication to continue lithium. For a large majority of, including my own follow-up patients, do continue and maintain well on addition of L-troxin, somewhere between 25 to 50. And as long as their thyroid status is controlled, as long as they are euthyroid and euthymic, nothing else to be done. So often just development of hypothyroidism, I often tend not to discontinue lithium, but negotiate with the patient and wait and watch. Having said that, a subset of patient will develop a more of a refractory hypothyroidism, often requiring large doses, and often in whom lithium does not work too well, even otherwise. So in a given patient, of course, you can switch, but one should not be too alarmed. It's a reversible side effect, and it's easily controlled.
Thank you. In one of your slides, you mentioned the term morningness. Dr. R.R. wants to know the meaning of that.
So morningness often is assessed through scales such as the morningness, eveningness questionnaire, and the chronotype. Many other scales are also available, the validated ones. There is a Hindi translation also of CSM. So essentially speaking, the hypothesis is that people with bipolar disorder are more likely to have disturbances in clock genes. So circadian genes, either along with the other genetic vulnerability inducing genes of bipolar disorder, they work to cause bipolar disorder or lead to the progression of course. So they directly, genetically speaking, can affect the disease, but indirectly through the rhythmic control of neurotransmitters, because the circadian genes also controls our social behaviors, what time we eat, what time we go to sleep, what time we meet people, what time we are most energetic. And so it is seen that people with bipolar disorder tend to have more eveningness compared to the general population samples. They are, when asked in these questionnaires, they are more likely to say that evening times are the best for them. That is when their brain works best. That is when they are most energetic. And that is a proxy marker that there is a phase shift, circadian phase shift, and which is not something induced by external factors, but which is a trait marker. People have been, the morningness, eveningness is evident as early as school-going children. And it is often a stable trait marker across our lives. So in people with bipolar disorder, more evening chronotypes are found. And in that subset, the course is also worse. Addition of lithium, not with a very robust data, but there are at least 4 or 5 good quality studies and one meta-analysis probably, which say that addition of lithium shifts the phase back to morningness and might be helpful.
Thank you. There is one question about your own personal experience with endoxifen in bipolar.
I have not yet used.
Okay, thank you. Dr. Meenakshi has a question. Suppose
I have been asked many times. There were times I have, but the cost, I think recently it dropped, maybe just last month there were, but for 2 or 3 reasons, I have not yet used it. Yeah.
Thank you. Dr. Meenakshi has another question. Suppose a patient has no or only partial response to lithium and valproate, then there is a role for the combination therapy of the two, lithium and sodium valproate.
Yes, but it would depend what kind of non-response is seen. If there are more depressive symptoms, then perhaps addition of agents such as quetiapine might be better.
Okay.
Or lamotrigine even, especially in Bali.
Thank you. Dr. Anupam Singh wants to know about the management of suicidality. Any escalation algorithm you would suggest if there is suicidality in a bipolar patient?
So first of all, suicidality has to be taken seriously. We know 1 in 10 of individuals with bipolar disorder will die of suicide. It's possible 5 times the person may come, the 6th time one may die. So it has to be a constant monitoring and it also has to come into the attitude of the trainees, especially from early years. The suicidality, generally speaking, is not something which should be dismissed. Having said that, we know there is often a comorbidity with personality disorder, and often the deliberate self-harm attempts with the varying degree of intent also are commonplace. So the management will depend on what is the conceptualization about suicidal behaviors and whether they are chronic or whether they have made a new onset. Sometimes patient will come and say कि बीमारी वापस आ गई है because 3 दिन से मरने के ख्याल फिर से आ गए. So of course, such patients who were remitted and the illness started with suicidality, these are serious suicide attempts, so who mean business. So they, for anyone with significant suicidality, admission must be offered. These patients, ECT, one should not shy away from using it. But having said that, only ideation, that too once in a while, no planning, no lifetime attempt, no other risk factors can be managed from OPD. And one usually would call such patients on weekly basis. One would also want to know the context around which suicidality happens and address some of those factors. One would also want to optimize the pharmacological regimen, etc. But
Very clear.
Subset is a serious. In one of my studies, we thought that we will eliminate this signal to noise and will focus only on people who have serious suicide attempts. So they were very lethal, serious suicide attempts. And once we chose to study, and it was more of a neuroimaging study, we focused only on that subset who were SSIs, that serious suicide attempts. But any degree of suicidality can have completed suicide, even unintentionally also. So one has to be careful. Lithium addition is one. Of course, in chronically suicidal patient, lithium should be preferred.
Thank you, very clear. You spoke about that molecular psychiatry paper about lunar cycles influence. Dr. Divina Kumar wants to know whether there is any evidence for a relationship between seasons and mood episodes in bipolar.
Yes. So that association is known for much longer. I tend to dwell on that paper because out of all the papers we come across thousands and tens of thousands of samples. Sometimes, small sized papers, especially with something new to learn, are more interesting. But as far as seasonality is concerned, yes, seasonality has been described, and there is a seasonality specifier also, with consecutive seasonal patterns. We know in Indian studies, there are both kind of patterns which have been described, both summer manias, winter depressions, and in an occasional patient, the reverse way around. And in such patients, there are two options. One is if there is very clear seasonal pattern and the patient is ready for monitoring and follow-up, one can cover prophylactically only in those months before the onset of winter. One can go for that, and especially if those are milder episodes. But
Okay,
having said that, a large majority of them, because there is no predictability, seasonal pattern is there for some years, but then it's not a lifetime course. So in those, you would want to keep the patient covered throughout the year.
Thank you. Continuing the discussion about the suicidality, Dr. Smita Ramdas wants to know about the role of oral ketamine in bipolar depression, if there is a superiority.
Yes, if the patient doesn't agree for ECT, of course, one would first want to, make all the arrangements, caregivers, etc. But yes, oral ketamine, I think Dr. Nilesh Shah sir has the biggest experience, and I think he's very well placed to respond to that question. I have heard, sir, with regard to ketamine before. So, sir, please, over to you.
Yes, we have been using oral ketamine in major depression, suicidal ideation, and even in bipolar depression under cover of mood stabilizer and or antipsychotic. So in the emergency situation, yes, if the patient is not willing for ECT or ECT cannot be given for some reason, ECT remains a gold standard. But for whatever reason, ECT is not feasible, oral ketamine is a good option. If somebody wants to know, very, very simple. We take 2 ml, that is 100 milligram of ketamine, put it in 300 ml of juice, stir it and ask the patient to drink it over a period of 40 minutes, 45 minutes. And we just monitor pulse, blood pressure, oxygen saturation over a period of 45 minutes. We do it once or twice in the OPD. Once the patient feels comfortable and the relatives are well equipped, they do it at home also.
Thank you, sir. So there is one question about, I think you ran through those slides. In geriatric population and pediatric population, what are the best agents for manic and depressive episodes?
CanMed gives certain some guidance. Lithium and risperidone, to my recall, for pediatric population in the case of manic episodes. And about the depressive episodes, let me just check, just to be on the sure side. So lithium and risperidone in mania, and lurasidone as far as the depressive phase is concerned. But the evidence for lurasidone is not level 1, it is level 2. And for maintenance, aripiprazole, lithium, valproate. And this is what is given in the CanMed guidelines.
Can I add?
Yes, sir.
See, we are lucky that whatever is available in Europe and America, most of the guidelines are based on that. Luckily, we have 2 other molecules. One is called Tiaprex, which is still available, and another is Blonanserin.
That is Tiapride.
Tiapride. Yes, Dr. Mohan Das is here. Tiapride. So, which is brand name is Tiaprex, Tiapride, and Blonanserin. That is available as variety of names. And maybe these 2 molecules have antipsychotic effects, and they are relatively less side effects. So, in Japan or Southeast Asia, Tiaprex is widely used in elderly people, and that one may consider for elderly people. And Blonanserin is also relatively less chances of EPR.
That is only in East Asian region.
Yes,
Okay.
East Asian regions, yes. We are so blessed that Dr. E. Mohan Das is the encyclopedia of psychiatry is with us.
Can I make some comments?
Sir, please.
Whether Shahul
Of
agrees?
course, sir. You need not ask for permission, sir. You are.
Yeah, it was a wonderful presentation by Raman Deep, because I am also a good old MD from Aldia Institute, late 70s. Happy to hear somebody from Aldia Institute. I thought it is exhaustive, not for a CME. It would have been short, and it is so comprehensive. I think in future we have to plan it to titrate down a specific. Okay, this is a suggestion. It was a wonderful presentation. Yeah. And I am very happy when you mentioned about the world's article in molecular psychiatry, you can pursue that Luna circle. But many of those things that you have covered is only my friends, CanMed guideline and Lakshmi's, and little bit of another friend of mine, Jinmalis, some of the diagrams, all right? Then I'm happy that you mentioned about Nasser Gaimi, another good, wonderful person. Now, somebody asked about suicidality. If you go through the British Association of Psychopharmacology guideline by the Murray Goodwin, even suggestion, even moderate depression, bipolar 1 with suicidal ideas, you may have to think of ECT or even antidepressants, but under cover of mood stabilizers. There's a controversy on antidepressants mood, bipolar, which I am not mentioning here. I have spoken many places abroad with all these friends of mine. Lastly, hello, can you hear me?
Yes.
Hello, can you
Yes,
hear
sir.
me?
Yes, sir.
And
Yes, sir.
you mentioned about a drug called brexanolone. It is IV. But for your information, last week, suranolone has come. It's an oral preparation for postpartum depression. Okay. Last week, US FDA has approved suranolone. And others you have covered within the time schedule or even crossing the time schedule. Very difficult for you to go into the etiological thing. That is another area by itself, whether circadian gene, gang gene, whether what is the role of glutamate in the switch, etc. Very difficult. Somebody asked a question on bipolar in pregnancy. That is a topic by itself. Anyway, you have covered at length, basically on CanMat and your own papers, and very happy to hear somebody from Old Institute, good old memories in late 70s. Okay, thank you very much, Shahul. Good way of doing it. And please continue with your CME program with upcoming leaders in psychiatry. And happy to see Nilesh as chair. Okay, and others, Srivastava is there. All my friends, thank you very much. Sorry to have taken
Thanks,
your
sir.
time.
Thank you.
It's okay, sir. Thanks for the comments, sir. So we will continue with the questions. There is a question from Dr. Sadish Verma about the dose of quetiapine in bipolar depression and whether the patients can tolerate the sedation at such doses.
Yeah. So before that, thank you, sir. Your comments were very useful. And the department is also holding an alumni meet this year. So we hope to see you over there. It's completing.
I don't know.
Sir,
whether I can make it.
It is only in the pipeline. So
Yeah.
it's completing 50 years. So hope to see you there. But thank you for your comments and also the new advent of the oral
Suranolone.
medication, Suranolone. Yeah.
And there are many in pipeline.
Many
Many in pipeline.
Right. Right, sir. Your comments are
Ashish,
always
Ashish.
useful in other forums also, as far as psychopharmacology is concerned. About the dose of quetiapine, yes, if it is, so we know that quetiapine can be given straight away at 200 also, if need be for acute episodes. But usually speaking, in our clinical experience, tend to titrate more slowly, especially if there is no emergency. And people, if usually tolerate well. I also have seen that bipolar depression typically requires lower doses of quetiapine as opposed to the other phases. So many patients, especially in combination, do well with as little as somewhere between 200 to 300 of quetiapine, and sometimes even less also.
Raman Deep, you go to the East Asian data, quetiapine, they are not tolerating well. Many of them have got postural hypotension and they use lower dosage. Okay, that is the East Asian data.
Yes. Plus that QTC interval.
That is rare. That is rare. Basically, postural hypotension and sedation. That is the East Asian data.
Yeah, Ashish, you are saying something?
Yeah, Shaul, thanks. Dr. Raman Deep, wonderful presentation. I have one experience to share and I want a question which is a little deviation from the main topic. I want to suggest that in my personal experience, I've been using for bipolar depression, mild to moderate, lithium plus bupropion combination, and that has been, I had not a single switch and a good response rates clinically. So that's one my experience I want to share, and you can go up to 300 milligrams also. It's pretty safe as such as switches are concerned. Second thing, I have a question, like many a times anxiety is very, very common in bipolar patients. The comorbidity, pan anxiety, most like social anxiety is very common. And the drug that we otherwise would have used is paroxetine, which gives a wonderful response for a social anxiety. But the moment you use it in bipolar, it gives easy switch. It's a worse drug. It's one of the not so good drugs for giving, causing switches. But what do we do? The response to other drugs, to my experience, has been very bad. Any drug that you would, any line of combination that you would suggest? I'm taking this opportunity because you are there, Dr. Nilesha is there, Dr. E. Mohandas is there. I think I've not got an answer yet to this problem of mine. Because the moment we give paroxetine, it switches. Other things don't work.
About the first comment, I agree. Bupropion is a good medication. It works well. And of course, it also has that NDRI kind of action. So it works well at certain symptoms and doesn't cause as many switches as we see. So I also often prefer, if I have to, then either escitalopram or bupropion at lower doses first. Now, the anxiety comorbidity is, yes, it's an issue in itself. Often anxiety comorbidity starts much early. It manifests in various kinds of GAD, be it agoraphobia, and also panic attacks intermittently. And now, to the first preference, of course, would be to try and manage it through agents which are not necessarily antidepressants, though eventually they may be required. Sometimes, for example, quetiapine especially at lower doses can serve anxiolytic purpose. Certain other anticonvulsant mood stabilizers, though not the primary ones, the one with not lithium valproate, but if we have to add, so they have some evidence that they might work in anxiety also. But non-pharmacological therapy is another which can be added. But having said that, both for OCD and anxiety disorders, there is always a debate of how much to expose the patient to SSRIs and for how long that the exposure should be. Some of the patients, especially those with bipolar 2, tend to do well. Even on, there are patients in my follow-up, they are on SSRIs or even SNRIs, but they are in bipolar 2 category. Whenever I taper after a year and a half, also they relapse. So then they say, mat taper karo, let it continue when it's not harming me. But on that, their anxiety and most of the other symptoms are remitted, and so there is no switch. But in people who tend to switch easily, of course, a good mood stabilization, maybe add another combination both to curtail anxiety, but also for better mood stabilization, and then give SSRIs if one exhausts other options. But I'm sure Dr. Nilesh Shah or Dr. Mohan Isaac, sir, would be able to contribute.
I am not Mohan Isaac, I am Mohandas.
Oh, sorry, Dr. Mohan Das, sir. Sorry.
Now, the first question, the bupropion, this is a decade back when the American Journal of Psychiatry article has come. Bupropion will not produce such anything, but it is a modest antidepressant. Bupropion is a very, very modest NDRI antidepressant. The dosing is up to 450 milligram, slowly hiking up 300 to 450 milligram for antidepressant dose, but it's a schizophrenic drug that you know it if you hike it. Fine. Secondly, anxiety as a part of this thing, if you go back to even one decade back, the Groves article, especially they say lamotrigine, is another drug which can be that you have mentioned indirectly. But currently people are going for a quetiapine. But there is so much, so many fans are there for quetiapine, though I am not a fan for this. Joseph Calabresi's talk on it, I critically commented on him on the face, but I am not a fan on, I mean, even with Lakshmi also, I am not a fan on quetiapine. Anyway, I am a fan of antidepressants, along with mood stabilizers in moderate to severe depression. I used to argue abroad also. Even now also, I am going to argue in WPA. I am going to talk on bipolar pharmacotherapy, depression. What is the current evidence? Very difficult. It is all individual choice and experience, rare cases, but there are some guidelines. You follow the guidelines and don't push up, don't do pill pushing, but you have to have a rationality in adjusting the dosage and the drug-drug interaction. And what about Raman Deep has talked is absolutely fine. That is the take home. You have to follow the guidelines and you see your own personal experience, individual cases, you can adjust it. Secondly, you even Lakshmi Yatham, Lakshmi has put it even the CanMat, especially the use of antidepressant. You mentioned about venlafaxine and fluoxetine, basically from the two articles of Amsterdam. Amsterdam is a person, not the place. Amsterdam study, whether it can be a mood stabilizer by itself. Okay, there are two. The one is on venlafaxine, another is on thing. But one is for bipolar 1 and bipolar 2 without any switch, continuation. So there may be some subgroup, as you have rightly told, which might require a small subgroup. We do not know the markers that your research or the circadian genes or others, whether it's a L-type channel, a responsive one, that is not a new thing. That is a good old one, L-type channel. Okay, L-pyridine channels. So we do not have full answers for all these things, but fine, follow the guidelines and try to adjust in the given patient and see what is best. And everyone is a researcher, they can do and they can have opinion. Okay, thank you very much.
Okay, sir, thank you. So I think we should not cross the 10 o'clock mark because it is going to be 2 hours. So I will ask one final question. After that, we will move back to the committee. The question is, especially that is a topic in itself. In a patient of bipolar 1 disorder with OCD, and where the OCD symptoms are the more distressing ones, how to go about the management?
There are articles, even Indian Journal of Psychiatry, Janardhan Reddy's article is there, and myself and another boy, now he is in Abu Dhabi, we have written on it, even reviewed it, bipolar with OCD, and Janardhan Reddy will be the best person to talk to. And articles are plenty, and I will not elaborate on anything. There are some ways of looking at it. Okay, thank you.
Thanks, Dr. Raman, your answer, please.
So I think sir has already answered. So maybe, that can be checked. The issues mostly like the comorbidity with anxiety, the similar issues are posed with OCD, but it's about prioritizing. If the bipolar is currently florid, one tries to manage that first because that takes priority. But if it's remission, long remissions, then of course OCD treatment can be prioritized. I think nothing further. Sir has already.
Okay, thank you. Sorry to the other people who have raised the questions because I think we should not run be more than 2 hours. So Ashish, over to you.
Thank you, Shah. Am I audible?
Yes, you are.
Yes, yes.
Just to introduce that we have been. Hello. We have been publicizing this. We are doing the offline program on 9th and 10th in Goa. My request to all of you, please come to Goa and attend this program. We have a wonderful series of speakers coming in. Dr. Sharma, Dr. Shahul, Sameer, Inal Shah, Alka Subramaniam, and Dr. Narendra Rao from Bangalore. So we expect a very good program lined up on Saturday half day, afternoon, and a Sunday morning program. We'll again send out with the detailed programs, we'll send out the brochure. Please do attend, and the brochure itself has a registration link. Anybody wants, please contact me on the number or the email given below, and we'll be more than happy to help you. It's a very small registration, but please do drop in it'll be a good program. Sincerely requesting for that. Thank you. Over to Dr. Niklesh. Is there
Sir, can I ask one question?
about the program? Yes.
No, sir. Actually, my last question was mine, and my question was not about the management. I know if the bipolar is more troublesome, then we have to manage that first. And if it OCD is more, then but what is the medicine of choice in cases where we know the patient is bipolar, but OCD is problematic, and there is a fear that if we go on to some or paroxetine or TCA, then patient might switch. So what anti-obsessive medicine should be tried in these cases? My question is that,
Okay,
which is
can
the
I
preferred
answer?
medicine?
So if I have to answer briefly, it's basically again the same principles, have 1 or 2 combination regimen, good mood stabilization, and among SSRIs, fluoxetine has it works wonderfully well on obsessionality, but it has long half-life. So in a given patient, yes, one may try, but then if the patient is naive, not yet tried, one can go for other SSRIs, which also work well in OCD, like escitalopram does work, sertraline does work.
Okay, and if patient is not responding to these medicines, then have you tried memantine and all? Are they working, and whether they
Memantine.
Can
your
I add to
experience
it?
of yes?
Okay, see, in OCD and bipolar mood disorder, they have described 2 patterns. One pattern is that patient has classical bipolar mood disorder, mania and depression, and only during depression he has OC symptoms. Now, in this kind of patients, OC symptoms are part of depressive episode, and you treat depressive as it is, and as the depression improves, OC symptoms also improves. So this has been well documented, and it has been also presented in different seminars by Dr. Janardhan Reddy. What Dr. E. Mohandas also said, that if OC symptoms are only part of depressive episode, then treat the depressive episode, and OC symptoms will also respond to that response to depressive episode. Now, if the patient has independent OCD, which he has OCD, and now he develops bipolar mood disorder, then both needs to be treated independently. So bipolar disorder, whatever you are treating, you stabilize the mood, and then we start with fluoxetine, clomipramine, oxazepam, memantine. We use regularly memantine. So these are the medicines. Because OCD is relatively treatment-resistant disorder. It's very, very difficult to treat. So undercover, once you have stabilized bipolar, mania particularly, with good mood stabilizers and antipsychotics, then you can actually treat OCD with full regime: fluoxetine, clomipramine, oxazepam, and memantine.
Thank you, sir. Thank you.
So I would like to just know if memantine is available as a brand, because I'm not aware. I asked.
Nemda, Admenta, Nemda, so many brands are available.
Thank you so much, sir.
Yeah, memantine is very easily available. Start with 5 milligram twice a day and increase to 10 milligram twice a day. We use it in OCD patient very, very routinely.
True, sir.
And I must acknowledge, I learned it from Dr. Sumant Khanna, who is the OCD specialist. One of my patient was not responding. I sent him to Sumant Khanna, Delhi. He started him on memantine and he responded. And that patient called me and said, "Sir, आपको एक सिखाता हूँ. अगर patient respond नहीं करता है OCD में, तो आप memantine add करें." सुमंत खन्ना ने मुझे memantine दिया और अभी मैं बहुत अच्छा हूँ. So thanks to Dr. Sumant Khanna. And memantine is useful in treatment-resistant cases of OCD.
Yeah. Thank you.
Yes.
When I have not tried memantine, I'll take a look into that.
We routinely use, on very first day we start memantine.
For OCD, I have not tried.
We routinely use right from day 1 fluoxetine, clomipramine, and memantine.
Hey, Turaja.
Shall we use-
could be one other option in such a case, of course.
Okay. Thank you, sir.
Yeah, Niklesh, are you there?
Yes, I'm here. Can you hear me?
I think Yes, yes, we can hear you.
This is our second program from Psychopharmacology subsection of IPS. I'd like to thank Ma'am Raman Deep ma'am for your beautiful presentation. And what more we have, if we have Professor Nilesh Shah to chair the session, who was the first author of the CPG on bipolar disorder. And we are really lucky to have Professor Imon Das for your beautiful opinion regarding all this. I'd like to thank all the IPS dignitaries, OPIDA and all other who are present here. And lastly, I would like to thank all the audience who have made their time to present here and make it a successful one. Thank you, everyone. Thank you.
Thank you, Dr. Raman. It was a wonderful program. And 2 hours continuous discussion. Thank you so much.
Yeah.
Thank you, sir.
Thanking the organizers for giving me this opportunity for this interaction, and also for the take home. I also had a couple of take homes.
Thank you, Dr. Raman Deep. Thanks for accepting our invite. Thank you, everyone.
We'll now close. Thank you.